Hello there, welcome again. This is Kamran Bhopal and I'm here with another emergency scenario which is on the TUR syndrome. So the question is, you're an ST3 in a DGH and you're doing a monopolar TURP in that DGH. You've got a 65-year-old gentleman 2 hours post-TURP, confused and agitated. The patient's got a low blood pressure, high heart rate and is pulling on his catheter and the security has been called. What are your differential diagnoses? So TUR syndrome, post-TURP bleed, urosepsis, PE, myocardial infarction or any other cardiac event. What is the likely diagnosis and how you would proceed? Number one, TUR syndrome, I would prioritize and immediately go and assess the patient as there's increased risk of seizures and coma. The next question is how to assess. A lot of people get stuck with this assessment, but listen to how I phrased this answer. I will assess this patient according to the CRISP protocol from the A&E approach and concomitantly look at the operative notes to look at any complications such as capsular breach, length of procedure, etc. My particular attention would be initiating resuscitation measures for hemodynamic instability. I will assess the bladder, whether it is percussible or palpable, and the contents of the catheter bags, whether there is any clots or blood. I will check his cognition, visual disturbance and pulmonary edema. I will also do some bloods and ECG looking for full blood count, Usenis, group and save, ABG and ECG. I would then discuss with my operating consultant and also the ITU team who may consider ITU invasive blood pressure monitoring, central line and even intubation in severe cases. 40 milligrams of IV furosemide or 1 gram per kilogram of IV mannitol can be considered. Hypertonic saline 3.6%, fluid restriction, but with the hypertonic saline, the sodium should not be corrected at greater than 1 millimole per hour. I would also inform the next of kin. This is a very comprehensive but concentrated answer. So, just write them in points and you have to say all of the things. TUR syndrome, you can't really perform resuscitation by giving him more IV simple fluids. So, you will the principles of management will come moving forward. So when they ask you how you will assess the patient, you mention that I will resuscitate him by years CRISP protocol, but giving IV fluids may not be the right answer, because if the patient got pulmonary edema and already has hypervolemia, you don't end up giving him more fluids. Obviously, and rather you do diuresis, but the patient is also unstable. So this is more just monitoring, intensive care, and via that route. So this is how I have structured my answer. What is the triad of pathological mechanisms? So number one, dilutional hyponatremia, number two, fluid overload, and number three, neurotoxicity, including encephalopathy, which is caused by glycine converting into ammonia, which causes encephalopathy, and visual disturbances, which is because glycine acts as a neurotransmitter. Predisposing factors to TUR syndrome, so pre-existing hyponatremia, early capsular perforation, procedure time greater than 90 minutes, prostate volume greater than 45 cc, and inappropriate irrigant height. How to avoid TUR syndrome? So correct pre-existing hyponatremia, avoid aggressive resection near the capsule, or complete the procedure if there's any breach. Limit the procedure to less than 90 minutes. Avoid overambitious glands greater than 45 cc. So all of these things, exactly as what were the predisposing factors, you go against that. And then there's three more in the avoidance of TUR syndrome. So height of irrigant should not be greater than 60 centimeter above the pubic symphysis. Use of continuous flow resectoscope and bipolar resectoscope should be used. Then intraoperative diagnosis. So intraoperative diagnosis of TUR syndrome, if the patient is under spinal anesthetic, you can talk to the patient and the patient is confused, it may indicate TUR syndrome and you should finish resection quickly. If the patient is under GA, hypertension may be the only sign. You can also use 1% ethanol tracer in 1.5% glycine solution, which is used with monopolar TUR, and you check the alcohol levels with a breathalyzer, and that's how you can check the amount of glycine solution in the intravascular compartment. Also, then we've got some operating tables which have got scales in them. So preoperative weight and intraoperative weight, and the difference between them can also indicate the amount of fluid that has gone in, and the fluid deficit running in and going out can also be measured. And lastly, you can mention reduced blood pressure, arrhythmias, and low saturations are late signs. So what are the principles of treatment? So number 1, intraoperative recognition and termination of procedure. Number 2 is monitoring. Number 3 is diuresis. Number 4, supportive care. In mild cases, you will check electrolytes, monitor blood pressure, heart rate, saturations, and respiratory rate, consider 40 milligrams of IV furosemide, fluid restriction, and inform the CCOT team or critical care outreach team. In severe cases, you will inform the HDU and ITU early, central venous line, arterial line, and intubation in severe cases, 40 milligrams of IV furosemide or 1 milligram per kilogram, 20% mannitol solution, given over 30 minutes, fluid restriction, and occasionally 3.6% hypertonic saline, and aim to correct less than 1 millimole per hour. Otherwise, it will cause central pontine myelonosis if done too quickly. Central pontine myelonolysis. So central pontine myelonolysis, they won't really ask what it is, but it is an important one to know. So basically what happens is, when you've got hyponatremia in the body, you get a lot of fluid shifting within your brain cells, which causes cerebral edema. So the body's mechanism is to push that fluid out of the cells, and by taking in pushing this fluid out of the pushing fluid out of the brain cells, along with releasing of salts from the brain cells, so that the fluid goes along with it to maintain hemostasis in the brain. If you correct too quickly, now the brain cells have low amount of salt, and the intravascular compartment has become normalized or improved significantly. So what will happen is that the salts within the brain cells are already low, and all of the water from the brain cells will rush out because the intravascular compartment outside in the body has got high level of salts. So the fluid will go out and your cells will become significantly dehydrated, and that is what will cause myelonolysis. So this is the mechanism between central pontine myelonolysis. So this is the end of your TUR syndrome, and I will be back with my next video, which is metastatic spinal cord compression. And I wish you all the best and hope you all get an NTN number. All the best. See you next time.